Hello, hello, hello. This is Kenny Perkins, aka your cancer guy. And again, as always, we bringing you another phenomenal guest. You know, Cancer, as we always say, and if you hear me say, it doesn't discriminate. It doesn't matter if you are white or black, rich or poor, young or old. Cancer is everywhere. And this is a global issue that we're dealing with. But today we're going to be talking about something that doesn't get shed, doesn't have much light shed on it sometimes, and that's pediatric cancers. There's a lot of young ones out here that get diagnosed. Now, I want you to imagine, when something happens to you as an adult, we can jump on Google. We can jump on asking someone, and, we may know someone and we may call them on the phone. But what about if you're a little one? Little pediatrics can't get on the line and on the internet and jump on and, hey, I have neoblastoma. You know, it's you need someone to advocate for you. And it's not enough. It's not enough. We cannot do enough to be able to get this word or this awareness out. So today, I got a special guest. This is our special, and I'm going to tell you, she is not only just a phenomenal human being, but she is a beast when it comes to getting things done. This woman doesn't sleep. She will sometimes stay in the hospital, sleep over because she needs to get the job done. And that's the kind of physician you want. That's the kind of person you want in your corner. Someone that's going to give you hope about what you're going through. Regardless of the staging or whatnot or the outcome, you want someone who's believing. In this next physician, we're going down to New York with this one, right? We're going to Memorial Sloan Kettering, right? Because this physician here is a fighter and she's going to advocate for you. Please, let's welcome Jess Puzzuoli to All Talk Oncology. Hey, welcome.
Hello.
Did I butcher your name? I feel I butchered your
It's
name.
okay. It's Puzzuoli. Everybody butchers it. You
Puzzuoli.
can
Give me
just
a
call me Dr.
Puzzuoli.
Jess. Dr. Jess. Yeah, Puzzuoli.
Give me a Puzzuoli. And, and Jess, it is a phenomenal experience being here in your presence right now. I am so happy because just talking behind the scenes with you is just incredible. The things that you're doing, your passion, and the things that you work hard for, and just for you to be in this space, in this part of oncology, peds oncology, it's a blessing. It's a blessing for everyone you touch. So thank you for that. Yeah.
Thank you. Thank you for having me. Glad to be here.
Yes. So for those that don't know you, give us a little background about who you are and how you ended up here in this space.
So, I so my baby sister, my sister Sarah, was diagnosed when she was 3 years old with stage 4 neuroblastoma. I was 8 years old at the time. Sarah was treated at Memorial Sloan Kettering at MSK. That's how I'll refer to MSK moving forward. Um, and she was treated for 10 months before she lost her fight. So she passed away about 1 month after her fourth birthday, and I was 9 years old at the time. And little kids are always like, I want to be an astronaut, I want to be a doctor, I want to do this, I want to do that. I had always been interested in being a doctor. Like my favorite Christmas gift ever that I could remember was getting the little Fisher Price medical kit when I was 3 years old. So I had already wanted to go into medicine in some way, shape, or form. And that kind of solidified it for me, and we really spent so much time at MSK during her treatment, between inpatient. When you're not inpatient, we had to go to a clinic every morning. And that was when I was like, I want to be you, looking at her team. And I know people think that it's insane to want to go into this sort of field in any way, shape, or form. But it's, I believe, a calling, and there was a reason for it.
Yeah.
So, and her, everyone that she was treated with at the time, and now you have to keep in mind this was back in 1991. So it was a very different world. There were no cell phones, there was no social media, there was no internet, there was no Google. Everyone has a fight page now where they have followers and support and all of this stuff, and GoFundMe's. That didn't exist. That did not exist at all. It was whoever was being treated on the floor with you at the same time. And, unfortunately, all of the kids that were in her cohort, if you will, did pass away eventually. But, that was basically what you had, aside from your family and friends that were, knew what was going on. But it was very different in terms of navigating than it is today.
Yeah, I can imagine. You
Yeah.
know, and think about that. I mean, you saw that here at a young age and decided, right, at a young age, I want to do that. I mean, what a not only a decision making, what a not only a big decision making from you at 9, but then to carry it out. I mean, that says a lot about who you are. When you make your mind up, things happen. So what is that's a it's amazing.
I get things done.
We need more of that. We need more of that.
No,
So
it's, it was, and people, it was a lot to digest at such a young age. And it's not, it's never normalized, but it became more normal for me to see little bald kids and, IV poles, and I knew how to read a CBC, and how to clean my sister's Broviac catheter and all this stuff at 9 years old, while like my friends were like playing on the playground. Cool. So it was just a very different way to grow up.
for sure. But that I mean, there's some things you can't teach. I mean, you live that experience, and whether you know it or not, what a way to honor your sister, right? She was battling that, and then you became someone who can help others battle because you know what that feels like. So what a way to give honor back to your sister. Yeah. So tell me a little bit about, you know, we don't hear a lot about pediatric cancers. Always the adults are in the forefront, and rightfully so, because they're the ones old enough, to put that out there. But that doesn't eliminate the fact that little little young pediatric patients are being diagnosed. So talk to me about a normal day at MSK. How many pediatric patients are you seeing on a daily basis?
So inpatient can be anywhere from 15 to like 30 patients. It depends. I believe right now we have about 150 active patients. I might have that number a little off, so sorry about that. Because you also have patients coming in for clinic and things like that who don't have to be who don't have to be inpatient, who are outpatient, who need to come in for their blood work every day, or for this or for that, or for treatments. So the thing with Peds Onc is that the incidence rates are actually rising. I believe now the numbers are, it's about 1 in 231 children before the age of 18 will be diagnosed. That is a crazy, crazy statistic. Um, so incidence rates are absolutely rising. I mean, as of like 2 years ago, it was 1 in 288. So things are going on here. Um, when you mentioned, adults being treated, and, obviously kids are people don't even realize that children can get cancer. There's still like a stigma out there for some reason. Um, the federal government gives $7.2 billion a year to the National Cancer Institute, the NCI, who is part of the NIH. Just to give you an idea of the amount of money that we get for pediatric cancer research, we get 47 million of that 7.2 billion for all of pediatric cancer research. So do the math.
across the US.
Across the US, we're all fighting for this money. Okay. And that is not like for one type of pediatric cancer. This is for all pediatric cancer. So you're talking I'm neuroendocrine. So I'm solid tumor and neuroendocrine. You've got soft tissue tumor people, sarcomas. You've got osteosarcoma. You've got glioblastomas. You've got DIPG. You've got brain tumors. I mean, all of us are fighting for only $47 million of a $7.2 billion budget. It is insane. And so if you look at any sort of childhood cancer advocacy fight pages or anything that involves anything with childhood cancer, you're going to see more than four, because what it is we only get 4% of the federal annual budget. And the problem with this, when I just mentioned that incidence rates are rising, is that when we do get the money, we are able to obtain the money, we have to be very careful about how that money is spent and where we put it for research. So it's like, well, do we want to look at treatment options and treatment development? Or, how are we going to look at this? And the thing that gets completely like the causes of childhood cancer are widely unknown still, because we don't have the money to look into why this is happening. All we know is we need to do the research to the research that goes on is to treat what's happening in the moment. Do you know what I mean? Like there's no prevention. Like we don't know about prevention. Everyone has their theories, but it's speculation. There's no solid research on, is it something, like parents always feel horrible, like they question themselves. Did we do something? Is it my fault? Like this, that, and the other. We don't know, so it's really the deficit here is in the lack of research. And that is why I focus so much on research, because as I've said over and over again, the definition of insanity is doing the same thing over and over and over again and expecting a different outcome. And that is the problem here. We need the research in order to change this cycle, because these kids are being treated with adult treatments. For example, doxorubicin was FDA approved in 1974 for treatment in adults. It's called the Red Devil, and it's the Red Devil for a reason. Not only is it bright red, like Kool-Aid red, but it also causes absolute havoc. It wreaks havoc on the system. The side effects are horrific and cause long-term cardiac issues, excuse me. And this is what we're mainlining into our kids because we don't have many other choices. So it's really like research is where it's at, and that is like my huge focus, because we're going to get nowhere if we don't have the research. And two-thirds of the children that actually do survive their cancers end up with secondary cancers, hearing loss. Hearing loss is a huge one. Almost, I would say almost 80% of the children that I've seen treated over the years have hearing aids and have severe hearing loss. Um, Renal failure, kidney problems. I mean, it's like it's chronic long-term life issues. So, yeah, so we need to really, really do a pivot and change things.
Yeah. Well, I mean, I mean, that is just, I mean, those statistics are crazy. And to know that the number is going up, it's how do we how do we get in front of that eight ball? Like, it seems like we're behind the eight ball. It's like, how do we get in front so that we can help out, especially with these little ones. I mean, you don't hear much about it. And, but obviously for those that are in the clinic and those that are in the hospital-based settings and dealing with pediatric cancers, you see all of it. I mean, 150 cases right now. Right now. So how what would you start? How about we do that? What would you start if you had to control on being able to maybe, do something with research, or what would you start at?
So, I mean, the number one thing obviously is funding. We need funding. That's number one. There's a lot of projects going on right now. So the goal, I know at MSK, I don't know about other hospitals, what their research programs look like. I know clinical trials, I know people at other institutions, and I know what they're doing, again, with limited funds. Um, and this, by the way, is not a new scenario. Like the more than four thing has been a thing forever. Like we have been desperately underfunded since the start of time. So this is not a new concept. Um, but we are really trying to go for targeted therapies. We're trying to go for targeted therapies where we're not doing these crazy systemic attacks with high dose chemo, that are destroying these kids' bodies.
And
Um,
just for the listener, systemic meaning the entire body.
Meaning the entire body, where you're just kind of mainlining like something like the Red Devil, doxorubicin, into these kids. And, it's not just killing the tumor, it's killing the healthy cells, right? So then they're going into multiple organ failure. While the tumor might be shrinking, but the poor kid's body, the kiddo is failing because of the treatment. Like the treatment often kills the patient. So we are desperately trying to move away from those days with targeted therapies. Immunotherapy is a big thing now. And we're using immunotherapy in conjunction with chemo, but it's lower dose chemo. It's not high dose chemo, and the immunotherapy is more targeted. So something that happens at MSK, and this is for any patient, whether you're a pediatric, an adolescent, an adult, is we have a database called Impact. And when you come to us, you get, your tumor or your cancer gets profiled. So you have basically, you're sequenced. So we can see what your mutations are. So then we can understand, let's see if we can manipulate the pathways that are involved in these mutations in order to basically tailor your protocol for you, right? Like we want to do, again, targeted therapy is where it's at. So that's where we're really driving things. My research, and I can't speak too much about what I have going on right now, but it is kind of going to be crossing over because I'm solid tumors, and I'm neuroendocrine. But the research that I have going on right now is we are looking at some therapies that were used on other cancers to now tailor them to not just solid tumors, but also to soft tissue tumors like sarcomas. So there's a lot of collaboration going on um, in our department. We all work together, and there are different specialties and different tumors behave in different ways. But we're trying to, one of the things that drives me crazy is when people say, and I understand it's people being concerned and like caring, but when they're like, we need a cure for cancer, and I'm like, yes, we do, but there is not a universal cure. Do you know what I mean? Like we're never gonna get there with that. And if we do, God bless the person that comes up with that. And I will, applaud you at your Nobel Prize, assembly, and I will go start a taco truck. But it's, like I will be more than happy to be out of a job if that happens. Um, but different cancers react or behave in different ways, and that's why there are different cancer types. There's different mutations, there's different everything. So like I just published a paper um, that I put out with a clinical correlation for two different um, mutations that we find in certain neuroendocrine tumors that happen to be in pancreatic neuroendocrine tumors. And, we find that what we found was when we did the clinical correlation that like these tumors that had these mutations, some would be completely resistant to ischemic treatment like embolization, and some would be totally sensitized to something like radiation in the same tumor. So, everybody behaves differently. You've got a lot of different people on the playground,
Sure.
you know.
You know, it seems like your background definitely being in research and figuring out different ways that you can treat these pediatric patients, something without like the red devil, as you brought out before. These are different type of chemo drugs that are used for adults, that are used for pediatric patients. You know, so it sounds like your research background is very strong.
Yes.
But let me ask you this, even from a standpoint of a human standpoint and a pediatric, how do you explain that to the kid? I mean, they come in not knowing, they're scared, they're seeing this thing, this transformation of their body, they're losing their hair. How does this conversation happen with them and the parents? Are you involved in that?
Well, yes, but so see, this is where I know when before we actually started the interview, we kind of touched on this. So there's, the difference here is that you're not just dealing like when you're dealing with adults, yes, adults will have their spouses or partners or families or whatever that are there, but they're an adult. In this field, the layer is that you have a patient that cannot really advocate for themselves. So the parents are what's going on, So again, I think I said this to you, we call them momcologists. They become experts, and the moms, they could have, and dads, by the way, but momcologist is a term. And if you go onto cancer pages and, childhood cancer pages, that is not a term that we coined. They coined it themselves, let me tell you. And they deserve, their own medical degrees. Um, so that is something that you really need to leave up to the parents, how they want to deal with it. Um, and, we have child life specialists, and we have a very active, social work department. So there's a lot of moving parts. that are involved. So it's not just nobody knows their child better than the parents,
Yeah.
right? So they know how to deal with it and or they don't know how to deal with it, but because who wants to deal with their child having cancer? But we do have resources for that. And it's at the end of the day, it's not my place to make the decision as to how to address that with a patient.
Yeah.
So there's like a very fine line that you ride, because there's certain cases where they don't want, like the parents or the caretakers, whoever they may be, don't really want the patient to know exactly what's going on. Like they don't want them to have like the full knowledge of maybe how severe the situation is, or if they're being released because they have to go home on hospice. Sometimes we're not going to share that information. We're just going to go home and make some memories and do our thing. And, it's very, it's a very individual, very specific to each family.
Sure. How with that being said, I mean it's interesting. With me, right, in radiation oncology, I'm dealing with all adults. So, the connection is important for me, right? Because it allows me to let them know that they're being seen, and then that also that I'm going to do my best to take care of them, and we do that every day, right?
Yeah.
And so I'm getting to know them. I'm getting to know about who they are. How do you connect with the little pediatric patients, or is it just about you just got to give them the treatment, and is a connection with the parents instead? How does that work?
So it starts with the parents, to be honest with you. And in all honesty, there are, and again, like social media can be evil, but at the same time, it has been of huge utility to the childhood cancer community. Um, there are parents that I have gotten very, very close with just through social media, who have children that are currently or were treated at MSK who were never in my sight when I was actually on site at MSK. And we are now all a network. So it's a very, very large network. And you have to, because you know what, you can't gain a child's trust without their parents trusting you. you know you can be great with kids. That's wonderful. Like we're in pediatrics. I walk around in like a unicorn hat and bunny ears on, like, and Muppet socks. That's one thing. But if you really like, it's super, super important. And that's, like, again, like I said, that's the other layer in pediatrics that you have to, that there's that other layer. You're not just dealing with one little tiny person, you're dealing with a whole, you know, commune of people, if you will, because
Yeah.
you've got parents, caretakers, the family, the friends, this, that, and the other. So I am on the board of WHIP Pediatric Cancer, which is a foundation that my friend Jordan Balaus started 10 years ago, actually. And she works very closely with MSK. And she just started a board, because what Jordan does is, what she used to do. There's two sectors of fundraising in my mind. One is quality of life, and one is research funding. Quality of life, like I do two benefits a year where I throw a huge fundraiser where we get all of the Halloween costumes and the candy for the kids because they have to celebrate the hospital. And then my other benefit is in December. It's actually coming up, in a month and a half or so, when I throw a big fundraiser where we get all of the gifts from the Amazon wish list that they do for their gift bags. So that's quality of life stuff, right? Like trying to like build up, happiness in some way, shape, or form, right? And that's what Jordan has been doing for years with pediatric cancer. And she does visits, she flies all over the country, visiting kids, doing gift bags, making wishes come true, trying to get tickets to things, Taylor Swift concerts, this, that, and the other. And Jordan and I have gotten really close in the last year, and she wanted to make a pivot because she realized after we got so close and talking to me so much about all of this, how important the research aspect is. So we now are going to be really focusing on research fundraising through WIP for MSK, for pediatrics.
I love it.
Yeah. So
That's awesome.
yeah, so there's a lot going on, and also through WIP, that's how we have so much connection with a lot of the families as well. So I have connections with pediatric cancer families that are not even have nothing to do with MSK, that were treated at hospitals all over the country and all over the world for that matter. So it's a very big network. And again, like I said earlier, it's a very different world than 1991 when my sister was, being treated in the hospital. So it's a huge network, and the more that we continue to band together and to push on and create awareness and push for funding, I think the further that we can get in this fight to actually make progress, constructive progress.
For sure. Well, let me ask this question. Since you brought up some great points, and I want to touch them and with the question. There's only so much funding that is allotted to the pediatrics, and then you also have this network now. You know, how is it? Are you allowed to share research with other facilities in order to try to come up with something? Because it's just, especially in pediatrics, it's just so limited. Or is it just everyone's in their individual silo? How does that work?
Okay, so it is competitive, that's for sure. The most competitive grants that you can apply for are NIH grants, and NCI is part of the NIH, and that's where the more than four comes in. We are very fortunate at MSK that we have very generous benefactors. So we have a lot of internal grant opportunities. But again, we're all fighting for those internal grants. So there are other funding opportunities out there. As far as other institutions connecting, those are called collaborations. And yes, we do them. Absolutely. People have different approaches, though. It depends on the lab, it depends on the physician, it depends on who you're talking to about their approach to how they want to try to make progress. Some people are more, we'll just use the word aggressive in their approach, in terms of treatment development. And then it's all across the board. So you find people, this is why conferences come into play so heavily, because when we go to conferences, you're seeing what other work people are doing, you see what they're interested in, you see where your overlap lies, and if you have a chance to work together. So it's there is a lot of collaboration. There's a lot of collaboration, and it's while it is competitive to get the grants, I think particularly in peds, we all realize that time is of the essence. We need to work together in order to do this. So particularly like right now, like I said, I can't really speak too much about the projects I have going on, but there's collaboration going on right now between like four different departments that I have like involvement in, at MSK at the same time. and we're trying to, we're trying to fund money, fund, research with WIP and get money in that way. And there's so much going on at all times. And, people are grinding. We're trying real hard.
I
So,
love that. I love that. And I believe anyone who may be going through the this journey in pediatric cancer is happy to hear that. That the collaboration is going on. What type of advancement have you seen? You talked about since 91, but what kind of advancement have you seen in the pediatric field for these little ones?
there have been things, and I'm going to name drop here, even though I should not. Dr. Naikon Chung, who actually treated my sister back in 1991, and who actually I'm like collaborating with and work with, which is
Awesome.
wild. And
So
I
awesome.
I fangirl over him secretly in my head every day, and I'm like, I can't believe I'm sitting next to you. But so he has basically been the innovator of monoclonal antibodies. So that is a very that came out. He started that work back in, I believe, 84, and finally was able to get it really moving. And then
In in layman terms, what would that be for my listeners?
so it's not a chemotherapeutic agent, it's not radiation, it's basically a targeted therapy. Okay. So he is the innovator of that. That is something that is constantly being worked on. And his first, I believe he had an FDA approval in, it was like 2006 or something, for one of the big treatments for that. And again, we're trying to get away from these cytotoxic treatments. So the antibody treatments are trying to steer away from this toxic chemo nightmare, that has been the standard for all of these years. Now, do we still need to do some radiation? Yeah, in certain cases. And I can't really, again, like that is involved in a lot in the work that I'm doing. But a big thing is immunotherapy. So the one thing that cancer is great at is evading the immune system, right? Like, so that's the hallmark of cancer. It can grow uncontrollably because the immune system does not recognize it. So the thing that we're working on is making the immune system recognize it so that the body can actually fight it on its own in conjunction with some other stuff,
Yeah,
but not where we're just blasting it and, having multiple organ failure because the treatments were so toxic to the rest of the system.
sure. And my hat goes off, and I'm sure the parents as well, to you and the team and research for pediatrics, because I mean, no one wants to see their kid having renal failure, hearing loss after you've battled and come out of cancer treatments, right? And then you're dealing with these types of side effects. No one wants to deal with that. So, thank you so much for what you do, in the research field and the collaboration and having the passion and the humility to be able to work with people that may not be uh, part of your team, but you still collaborate with them. So thank you. Thank you so much for that.
Well, it's a team effort for sure at MSK. I really haven't been at many other institutions in this capacity. I am an MSK cheerleader, as you probably have figured out at this point. Um, but everyone works with everybody there. It's a team effort for sure. And the thing with these kids is they have to keep coming back, for their routine scans even after they're deemed cancer free and there no evidence of disease. And anxiety, that's what we call it, the anxiety of scanning, as I'm sure you know, yeah, is a very, very real thing. And a lot of these kids, I mean, most of them, I want to say probably the majority of them have, you know, moderate to severe PTSD from the treatments that they endured and their experiences and going through this whole experience. So, that's where child life specialists and even our playroom, like everybody comes into play when you're dealing with something like this. Like there's no, the people in the gift shop smiling at the parents and giving them coffee, like great job guys, like the parking garage attendants, like it's an operation from the bottom up and the top down. So and that's for any cancer patient, anywhere. But we take great pride in what we do, at MSK, and particularly for our pediatrics, but for all of our patients. And it's we are all invested, and it's something we're passionate about. We take it very, very seriously. That is not, we're not just like rolling in like, oh, I got to be at work again. This is a lifestyle.
Yeah, I love that. And shout out to MSK for just having that culture, right? And that it is a lifestyle. It's a culture that you guys, have taken pride in. And thank you guys so much. I mean, it's important when you got people from your parking valet to coffee to the physicians cheering you on, it that brings some type of feeling, some type of joy inside, and knowing that you're in the right place, right? And you need to know that. You need to feel that. You need to feel that you're in the right place when you're going through something like a cancer journey. And so, thank you to MSK for being who you guys are and being world renowned. So, wanted to take that time and shout you guys out for that. But yes, what a great. I don't know what I want to say. What a great what. It's like I'm just so stuck with that. I mean, just what a great opportunity that you have, that these cancer patients have, because people like you are in the right position, and we just need more of that. And if we can do from Jordan, from Ped Cancer Foundations, and traveling the world in order to get more funding, then by all means, let's do it. And I want to make sure that I put this out and people know that, pediatrics is suffering in the sense of funding for that. And I don't think people know. I didn't. So how would we? And a lot of times we don't know much about cancer anyway, let alone that there's a shortage in the pediatric field for oncology. So thank you so much for shedding light on that today.
Yeah, until it knocks on your door, you most times don't know. My family was not a pediatric cancer family until, my sister, got diagnosed. So that's kind of how it goes. And if you're not in kind of the childhood cancer circles, or if you're not in the field, a lot of people don't realize, what's going on with the funding and why we can't make advances. And we're working with what we've got, and there are advances being made. But it's a struggle, but like we are willing and able. I mean, some of the most brilliant minds are ready, raring to go. Like, and it's we're working with what we've got, and we'll find the money. We always somehow find the money, and we're gonna find more money because things are progressing, and we know more every day. We know more and more every day. And that's basically, just keep grinding.
Sure. Now, Jess, before we let you go, what is something that you would like the listeners to walk away with and knowing, Jim, that you can give them?
I would say, I mean, again, obviously I've been pontificating about about funding for this whole time. I think that it's just an awareness of childhood cancer and just how many children actually are afflicted by this in our country alone. 7 children a day die of pediatric cancer in this country. The numbers are atrocious in how many diagnoses there are a day. And it's just an awareness that this is a serious, serious issue. It is a problem. And the funding is certainly, certainly an issue. And anything you can do to kind of educate yourself or Google about or just kind of check it out. And if you have the means to even contribute to anything, that would be wonderful. If you don't, just knowing about it and being aware is more than enough in my mind. Um, and yeah, just know that this is reality. This is something that really exists, and there are a lot of people who are working really, really hard to make this not such a reality.
Yeah. But just we really appreciate having you here on All Talk Oncology, and thank you so much for what you do, for taking the time to put in the energy to do the research and having the passion. And we all know where that passion comes from, as we talked about, as you told us today, your sister. And like I said, what a way to give back to her and honor her. And so we thank you for that. We thank MSK for the work they're doing, and we hope that we can continue to make progress in the pediatric oncology field.
Thank you so much for having me. This was lovely.
It's our pleasure. And so for
Any
all those,
any chance I get to talk excessively about this, I'll take.
yes, absolutely. And then listen, we're going to be counting on you when we hear some advancements that are taking place. You're working on some things now, and we know
Yeah,
we're,
there's
we're
there's there's stuff going on. So
yeah,
we
that's
got the wheels are in motion. So there will be news. It's gonna take about a year to get things out, but we've got more stuff coming and it's big stuff.
I
So
love it. I
yeah.
love it. And when that happens, I want to be the first to get you on here and let's talk about it because, we want to always stay optimistic and knowing that there's work being done. And then even if you've been diagnosed, just know that there's people out here that is fighting for you, fighting for the research, fighting to find ways to eliminate cancer, finding ways to at least destroy these tumors or maintain them, or leave us so a person can have a decent lifestyle, and out of this situation. So it's being work is being done. So just know that.
Yep. 24/7 it is. So
And so, all my listeners, I want to tell you, you listen to me, you're not alone in this. Sometimes you're going through something like this, and this is why we bring, the doctors like Jess on our show so she can shed light on it so that I mean, she talked a lot about funding. She just wanted to bring that awareness that there's a lack of funding in this field, but know that there's things being done, and she's there battling for you. If you need anything, MSK is a facility that you should look up. Look for Jess. She will direct you and make sure that you get the help that you need. Anything else, Jess, would you like to conclude before I close us out?
I think that's about it. I will say one last thing. Um, Someone asked me one time, or remarked one time, um, when one of our patients passed away. And, knowing my background, having lost so many children, in my sister's group, having lost my own sister, I went to more funerals of children by the time I was 9 and 10 years old than I think people go to in their entire lives for adults. Um, And someone said to me, this was a couple of years ago, we had lost a kid, and they were like, "Oh, well, you must be used to it by now." And I was like, "Oh." It was one of the most jarring comments anyone has ever made to me in my life. And no, you never get used to this. There is nothing that should ever be normalized about any of this, no matter what age of the patient, no matter what the situation is. Um, you are invested in their well-being, and this is, we don't go home at night and stop thinking about what's going on back at the hospital. And that's on the research end, and that's on the clinical end. The brain is constantly moving. So, we are gunning 24/7. So, you know, patients are constantly on our minds, and it's never normalized, and we are not okay, about it. Like, we have to put on a professional air, but we're not okay either. Like, this impacts us as well. And we are invested. Like, this is not, oncology in general is not a normal field to want to be in because it is rough. So, we are there for you. So that's basically the end of my pontification.
Thank you so much for sharing that uh, heartfelt feeling with us. And it makes me think about another question before I let you go here. You know, for you, you've seen hundreds of people not be successful. And so for the parent that comes in with their child and it's individual, right? These individual parents are coming in and they're dealing with just the one. What can you give them as far as how you cope or how you deal with it, how you get a mindset so that they can benefit from that? Because they're dealing with the one you've seen, unfortunately, a lot.
Yeah, and it's tough questions because what like what's your first question when it's your child that you're bringing in and you find out they have cancer? Are they going to make it? That's the first question. And that's not a question that you can necessarily answer. I mean, unfortunately, there are some very tragic circumstances where the situation, for example, DIPG, diffuse intrinsic pontine glioma, that is I think the 5-year survival rate is 1%. The Upon diagnosis, the children only make it about 9 months at best. I mean, it's a death sentence. So you have a cancer like that, and that's again in the brainstem. And then you have other cancers where we don't really know. We have to see how they react to treatment and this, that, and the other. And then again, that's where like the network, because it's kind of like circling around answering questions, if that makes any sense. Like, you can't give like, oh, they're going to be fine, because that's not reality. Like, we don't know. And you want to be optimistic and you want to be supportive, but you also cannot give false pretenses about what's going to happen. So it's a very it's a dance, if you will. And I don't mean to minimize the severity of how important those conversations are. But again, that's also why we have teams. We work in teams. So you've got your surgeon and your this and your that and there's a pathologist, and then you've got social workers, and we have child life therapists, and there's support coming from many different areas. So it takes a village for real, is essentially how it works. Because you have to be very careful about what you say because you want to be optimistic and you want to be supportive, and we are. But you also don't want to give, again, you don't want to set false pretense.
For sure. Is there something that you're able to do in order to come to work every single day, even after going through these experiences? Is there something, what is it that you pull from that allows you to come in every day?
I just love what I do. I love what I do. I mean, it's not easy. If, I would be lying if I said that it didn't or it hasn't taken a dramatic toll on my body physically, mentally, and emotionally. I would be absolutely lying to you if I said that that was not the case. But we have mental health checks and things like that. And, I've gotten better now at trying to take more time, like with my husband and, with my friends and not like living at the hospital constantly. Because there's a guilt there too for me. I feel like I need to be there all the time. So when people talk about work-life balance, it's it's a very real thing that needs to happen. And I realize that. I just need to materialize it. We're not quite there yet, but I'm working on it.
For sure.
Um, yeah, so I have a decent commute into the city every day. I take the train along the Hudson River every day. So my kind of time to get my head in the game and try to breathe is, blasting music and sitting on the train looking at the Hudson River and, trying to breathe.
Sure.
So,
You know what? I appreciate you. I appreciate the transparency, and you know why? Because you're not alone in that. We all are. A lot of us, not we all of us, a lot of us. And trying to find the balance it's so difficult. And I asked you that question because I'm going to give you the personal experience of me. So I was on a podcast and they asked me, Kenny, why do you do this? And I said, the answer at that moment was because I love people. And that was the superficial answer I gave them because I didn't. That's what I was saying. But when
yeah,
I thought about it, Jess, and I thought about why am I doing this? I love what I do. I do love it. But why? And I thought, you know what? I know what it's like to be counted out. And that was it right there. When I sometimes when you're a cancer patient, it's like, for a lot of people think that it's a death sentence and they feel counted out. And I
yeah,
know that feeling. And so for me, understanding that some people feel that they're being counted out and being there for them is what drives me and why I love what I do and love connecting with people and love creating this whole show for All Talk Oncology. And so I can only imagine, and I asked that question, and you don't even have to give the answer at this point, but I know you love your job, but what is it that allows you to continue to come to work every single day? And your sister being obviously the cornerstone of that for
yeah,
sure.
absolutely. No, absolutely. And I'm a people person. I love people. I'm a compassionate person, and I just find a lot of joy selfishly in helping others. And I know that that sounds kind of very like simple and stupid maybe, but that's just the bottom line to it. You know, I have a lot of passion for my research. I have a lot of passion for what I do. And I see, you know, the fact that there's such a need for it too in our field really drives me. And the things that we see, you can't unsee, you know, on a daily basis. And the things that we know, you can't ignore. And it's like, I know I'm willing and able. I know I have the brains and the education and the you know the drive and the energy to do it. And if you're willing and able, you got to get on the front line and do it. And that's kind of where we all are there.
Yeah.
So,
Thank you. Just thank you so much. It's been a great experience having you here. Just a pleasure being able to sit here and just be educated about what's going on in the life of pediatric oncology. And
well, thank you so much for having me. And hopefully, when my papers go out and we can have another talk about big things happening.
love it. But absolutely love it.
All right. Thank you so much,
Listen,
Kenny. It was
listen,
great speaking with you.
sure. And so for those listening in, listen to me. I hope you benefited from this conversation because our conversations are meant to be empowered. We want to empower you through these insightful conversations so that we reinforce confidence and certainty about your cancer condition. And as I always say, you're not alone in this. We're in this together. This is Kenny Perkins, aka your cancer guy. Until again, I'm out.
So stay connected with us on All Talk Oncology Cancer Podcast. Make sure you subscribe to that, right? Wherever you listen to your podcast, whether that's Apple, Spotify, make sure you subscribe and continue to spread that word, right? Engage in this because your engagement can help someone stay alive. And this is what we're talking about. So again, make sure you subscribe, hit that subscribe button. Again, this is Kenny Perkins, aka your cancer guy. Until again, I'm out.